Yeah. Uh, yes. Good morning. We are talking about post-tuberculous kyphosis, and if we divide this into two parts, uh, like the adult onset kyphosis and the pediatric onset kyphosis, the pediatric onset is usually more severe, usually more than 100 degrees. It can reach even up to 160 degrees or so. And the main thing is there is a lot of difficulty in correction because the soft tissue is very rubbery and difficult to handle, and hence there are more chances of having cord handling and the neurological complications. Hence, the early and preferably global fusion is the need of the day. Yeah. For example, this particular case having multiple vertebral destruction with only 40-degree kyphosis, which if treated earlier could have been much better, but landed up after 5 years into about 140 degrees of kyphosis there. In contrast, the adult onset usually, for example, this case, this is about 3.5 body destruction, but still has settled with toppling and fused in about 80 to 90 degrees of kyphosis there. So in a wet cox, how do you correct the deformities? For example, in this particular case, one body completely destroyed, day 6, there we can go ahead with anterior open wedge correction also, like through as said earlier in this seminar, you can have an anterior transthoracic or a retropleural approach. uh, Go debride it and put a cage or a bone graft and as well as instrumentation anteriorly there. Another way is you can go ahead and do a posterior closed wedge osteotomy there. You put an upper instrumentation, put lower instrumentation, excise the posterior and lateral elements, including the pedicles, and then you close the wedge. But when you close it like this, there are chances that the cord will get crumpled, especially if there's destruction of one or more bodies there. So in that case, we put a cage anteriorly so that you just jack open it a bit anteriorly so your cord gets straightened. If required, you compress it posteriorly so you get little extra correction. That is called as the anterior open wedge correction and the posterior closed wedge corrections there. So say, for example, we'll take one by one example. In this particular case, young lady with one body completely destroyed and fused with about 57 degrees of kyphosis at L1 level. Now, how do we proceed? Okay. Now, instrumentations. We mark the pedicles, the apical pedicles, mark the pedicles. We cannulate the pedicles and dilate the pedicles with the help of the torture. Right? And then with the help of the curate, you start curating the vertebral bodies through the pedicles in a triangular fashion with apex at the anterior cortex. And then finally, you connect both the pedicles by gently retracting the dural tube and biting out the posterior cortex of the body with the help of the rongers there, and then applying compression over a rod, you get a beautiful correction. This is called as pedicle subtraction osteotomy or PSO. But if you want a little more correction, we can have a cut going to the lower part of the upper body, or even in fact even a little more higher there, and the lower cut going to the upper part of the lower body, and we can destabilize the spine and get more correction. This is called as a vertebral column resection there. So a pedicle subtraction osteotomy is an inherently stable because we are working within the confines of the body. So it is the stability of the spine is still preserved, though it gives less correction about 20-30 degrees at one level. If you want more correction, you can have a multi-level PSOs. Also, you cannot have an anterior open wedge. In contrast, in contrast, um, the vertebral column resection, you can resect any amount of the wedge. The more the degree of the closed wedge, the more are the chance of having more crumpling of the cord. So to prevent that, we usually put an anterior cage to jack open the anteriorly to prevent any crumpling of the cord, and then close it posteriorly. With this method, you can get more angular correction with a smaller degree of wedge. Let us see how. See, in this case, this is about 60 degrees of kyphosis at a level of L1. So you add about 20 degrees of normal lordosis. That adds up to about 80 degrees of the overall correction. Okay. To get a posterior close wedge, 80 degree would amount to a lot of bony resection of the vertebral bodies. Rather than that, if you take the cut to the lower border of upper body and upper border of the lower body, that will amount to about 40 degrees of a posterior wedge resection there. After that, once the osteotomy is completed, if we add cage, we get about another 20 to 30 degrees of correction. And after instrumentation, when we apply compression over it, we get about another 20 degrees of correction. So with a little 40 degrees of wedge resection, we can get up to 80 to 90 degrees of correction. Okay, so this is what we call as a vertebral column resection with anterior open wedge and posterior closing wedge correction there. So now let us see how it is exactly executed here. Now in this case, exposure, instrumentation, removal of the posterior body and the lateral elements. We went according to the plan and started scooping out the bone anteriorly. There we saw to it that the anterior bone is removed, the column is destabilized, and then the interbody distractor is being applied. Had to jack open it anteriorly. We put a smaller cage and then we reduced it over the rod there. Okay. And that was a 3-year follow-up X-ray. Let us see in thoracic spine, another. It's about 2 bodies destroyed, about 1.5 to 2 bodies destroyed with around 60-degree angular kyphosis. Now, a thoracic spine, upper lower instrumentation is same. The only thing is entering the body will be around the vertebra, because then you don't want to retract the cord there. So you'll have to have a little far lateral exposure, remove the ribs, and then expose the outer aspect of the vertebral body. But before you start doing it, please apply the working rod. Working rod, as thoracic spine does not tolerate any instability there. So after removal of the anterior body, remove the posterior elements, the lateral elements. The cord should be free. The both lamina, upper and lower lamina, should be domed to allow for any cord swelling. And then an adequate size cage is placed properly. Apply compression over the cage, and then you put in a morcellized bone graft around the cage, and then a lot of bone graft on posterolateral side also. And that's how the final correction almost it is. And this is a 7-year follow-up. So in thoracic spine, it's better to go from outside and no cord retraction. The roots can be sacrificed and number of instrumentation level is not a problem there. But in lumbar spine, you can do PSOs, you can work within the body, but the roots needs to be saved, and of course you'll have to save the mobile level. So no excess instrumentation. But at the same time, you should not compromise the stability also. So if you want to add stability, you can add augmentations like sublaminar wires, and still, if required, you can extend the instrumentation but without fusion, so that you can remove the instrumentation early and patient will regain his movement there. So let's see this 3-level involvement at DL junction. Again, this was a conglomerate of 3 vertebrae, D12, L1, L2 with 85 degrees of lordosis. 85 degrees of kyphosis, and if you add 20 degrees lordosis, that's about 100 to 105 degrees of overall correction required. So now, where do we stop the instrumentation? Like in scoliosis, we have something called as the lowest instrumented vertebra. Now, which one is this? Now, here we have the posterior superior vertical sacral line there, or what we call as the lowest zone also. The vertebra which is most bisected is the most stable vertebra there. So here the LIV is L4 there. With this much kyphosis, but only 2 vertebrae might be less in the whole. So then we'll have to go up to L5, but then I don't want to leave it with only a single mobile segment. So what I would do, I will remove the L5 vertebra. Rather than that, I'll put a a small apical vertebra into L2 and modify my osteotomy above the screws, because this apical vertebra screw is extremely important in stabilizing also. This is basically like a rule of thumb correction. There. So that was the exposure, the marking of osteotomy, instrumentation, removal of the posterior elements and lateral elements, and then the lower marking site looks to be absolutely good, just above the L2 pedicles, but the upper marker is bit heavy. So we corrected the marking of the upper vertebra, the uppercut. So that is where we wanted to have the uppercut, and the lower cut was like this. This was D12 L1 roots. We'll have to work around the roots. So once the dural tube is free all around, the bone is disconnected. Of course, the working rod is applied, and then you apply slowly an under contoured rod there. And once the under contoured rod is applied, I applied an in situ bender to correct it, and then achieve the compression slowly there. Okay. So, and then achieve the final compression over the cage. So after the in situ bending, once you compress it, because in situ bending will open up anteriorly, so it might stretch out the cord to certain extent, but so immediately apply some compression, so that will relax the cord. At the same time, it reduces the anterior space also, so you apply a little smaller size cage. Okay, that was the final correction. So the sequence: corpectomy, in situ under contoured rod, then in situ bending, compression over in situ bending, then the cage placement, the final compressions. But another popular method which I use it also commonly, and very common method, is once you do the corpectomy and the posterior lateral element crosser, then you do this, preferably with the help of reduction screws. Use sequential application of gradually reduced under contoured rod. So for example, this was an 80 degrees rod. You apply about 60-degree rods, and you loosen the opposite side, and you start tightening on one side. And then once this is tightened, you apply another rod, and then you gradually loosen this and tighten that. So you gradually get the corrections. Okay, so that was final corrections. For this particular case, I wanted to show you, this is an extremely more than 5 bodies destroyed in an adolescent girl with 110 degrees of lumbar lordosis. She was operated earlier for an ALD approach. So she was interventive, but this was not adequate intervention. We need to have not only anterior but also the posterior fusion. If this would have been done earlier, she would not have landed up with such a huge kyphosis there. This was the reformed ribs there. So her LIV is L3. So a lower instrumentation, upper instrumentation. Now if you see here, the upper dorsal part almost has about 60 degrees of lordosis. So to restore the kyphosis, we need to do some pontage release for that also. And then the amount of wedge. Now if you go at the apex of the kyphosis, if you remove a wedge this much at a level of about 160-degree kyphosis, the correction would be even extremely difficult. But if we exercise a little more wedge, say at a level where it is about 145 degrees, there the correction might be a little more easy with the help of a cage there. So that was her positioning. We use the same incision, exposure, instrumentation. This was the reform rib, which was excised. This was neurovascular bundle, which was excised, and then the lateral aspect was exposed. And yeah, that was the internal gibbous, which was started excising, and that was the last part of the posterior part of the vertebral body, the internal gibbous, which is excised, and the cord lying free. Now, one thing I wanted to tell is these are the ends of the bodies, and that was the internal gibbous. The cord was tented like this. Once you remove the internal gibbous, the cord falls free. But if you don't remove this particular reach of the bone, then the cord might get tented again at the ends. So here you can see the cord is completely free, and then the under control rod is applied and it is gradually corrected over a cage. So that was from 160 to 50 degrees, and that was her cosmetic correction. This, but my request and my teaching is that it should not progress to this level. This was a final. Okay, so even in this extreme 7 to 8 level destruction from C5 to D5 in a small child, if you don't understand what to do, do something what we did it. Do an internal splinting posteriorly, okay, with the help of some screws and some sublaminar wires, and then decompress it anteriorly with the help of a costotransfectomy, or do something whatever little anteriorly you can do it there. But then you maintain the correction, to maintain the reduction. And pediatric people, they throw sometimes some miraculous results, and the anterior bones have reformed so well. We removed the implants after 3 years, and you can see the final results. Okay, so a timely intervention and adequate intervention is the need to prevent any kyphosis. Thank you very much.